Good evening, everyone. Now we are live. Welcome to OrthoTV online Ortho Excellence series. So to introduce today's program, I hand over to our moderator, Dr. B. Shivshankar, President-elect of Indian Orthopaedic Association. Good evening, everyone.
Good evening, everybody. Friends, we have a very interesting topic today. How to be a supracondylar champion. Lessons learned by me over the last 2 decades. This is none other than a pediatric orthopedic surgeon from Bangalore, Dr. Jayant Sampath. We also have expert panel in the form of Dr. Mandar Agashe from Mumbai, Viraj Shingade from Nagpur, Dr. Ashish Ranade from Pune, and Dr. Rajendra Chandak from Nagpur. Of course, we have Neeraj Bijlandi and Ashok Sham to coordinate the technical issues and take the questions which might appear on YouTube or OrthoTV channel. To introduce today's speaker, Dr. Jayant Sampath. He has done FRCS Edinburgh in trauma and orthopedics and is working as consultant pediatric orthopedic surgeon at Rainbow Children's Hospital, Marthanhalli, Bangalore. Friends, Dr. Sampath has completed orthopedic training from Manchester, United Kingdom in 2002. He has done pediatric orthopedic fellowships at Al Depot Hospital for Children, Wellington, Delaware in USA, and Booth Hall Children's Hospital in Manchester between 2002 to 2004. He has worked as consultant pediatric orthopedic surgeon at Alderhay Children's Hospital in Liverpool between 2004 to 2010. That's almost 6 years he has worked there. Then since 2010, he has come back to India and is practicing at Bangalore. He manages all pediatric orthopedic conditions and children's fracture. He has special interest in cerebral palsy, neurovascular disorders, and gait analysis. He was the first to establish the clinical gait lab in Bangalore in 2013. And he is also working as the editor on International Journal of Pediatric Orthopedics. He is the executive committee member of Pediatric Orthopedic Society of India, and he has more than 25 publications in several books and many chapters in several books. Welcome, Dr. Jayant Sampath.
Thank you, sir.
I met him when I have visited Bangalore many times, but the opportunity I had was when we traveled together for the mid-year meeting of Jharkhand Orthopaedic Association at Betla National Park in Daltonganj in 2018. So we traveled together from Ranchi to Betla and again from Betla back to Ranchi, and we were together for 3 days, and we visited one of the fort there. It's in the pure jungle, heart of the jungle. We were there for 3 days. That was one of the best time I have spent. You can see the such lush green Palamu National Park that is in the Betla Daltonganj. So you can see Dr. Jayant Sampath with me during that time. We have Dr. Mandar Agashe, a pediatric orthopedic consultant from Mumbai. He is the co-director of CHIPS. CHIPS is Children Hip Preservation Services of SRCC Children's Hospital. This is SRCC Hospital is a Narayana group of hospital. Then he is also director of Agashe's Pediatric Super Specialty Clinic in Mumbai. Welcome, Dr. Mandar. We have Dr. Viraj Shingade from Nagpur. I have heard him so many times. He has a lot of work, especially on radio ulnar stenosis. I have seen almost 40 of his cases in one of his presentations. So he's working as pediatric orthopedic surgeon and director of children orthopedic care in Nagpur. Welcome, Dr. Viraj. We also have Dr. Rajendra Chandak, a general orthopedic surgeon, but specialized in everything. He's jack of all and master of all. So he's a complete orthopedic surgeon who has received gold medals when he passed his MBBS and MS from Government Medical College, Nagpur. He has done AO master course, AO advanced course, and AO pelvic course also. His area of special interests are difficult and complex, challenging trauma and reconstructive surgeries and non-unions and malunions. Friends, he is the first to do a reamer irrigation aspirator for a long segmental bone missing in tibia. Almost about 10 years back he has done when the RIA was just in the nascent period in the international market. He has published handbook on preoperative planning of orthopedic instruments, published a handbook on stages of fracture healing and patient education guide, presented papers at various international, national, state and regional conferences designed. He has also designed a patellar suture needle. Dr. Chandak every year attends AAOS meeting and he brings back lot of knowledge and he implements them in his practice. We have Dr. Ashish Ranade, who has done his MBBS and MS from Pune, BJ Medical College, and then he has done MRCS from Ireland. After completing his MBBS and MS, he specialized further by acquiring MRCS from Royal College of Surgeons in Ireland, Dublin. After spending 7 years of his career in India, he got the opportunity to work in UK, where he spent 3 years in several positions like clinical fellow in Whittington Hospital, London, senior house officer at Western General Hospital in Weston-super-Mare, and clinical fellow at Yeovil District Hospital and Frenchy Southmead Hospital. After his successful stint in UK, he went to US where he did his fellowship in reputed institutions like Shriners Hospital for Children in Philadelphia and Mount Sinai Hospital in Baltimore. He also spent the year working as instructor in orthopedics at University of Arkansas for Medical Science at Little Rock, Arkansas, before returning back to India. He has over 20 years of experience and is an orthopedic surgery specialist at Columbia Asia Hospital in Pune. Welcome, Ashish. So with this brief introduction of the faculty, I hand over this presentation now to Dr. Jayant Sampath to share his screen and start the talk on how to be a supracondylar champion, lessons learned over last 2 decades. Welcome, Dr. Jayant.
Thank you, sir, for the kind introduction. I'm very happy to be speaking today about supracondylar fractures, which is probably the commonest of the difficult fractures in children. And certainly the reason I have put last 2 decades is there has been a huge amount of change in the way we think about supracondylar fractures and the way we manage supracondylar fractures. So I think each one of us, whether we are a pediatric orthopedic surgeon or a general orthopedic surgeon, all of us manage supracondylar fractures. So it's incumbent upon us to manage it well. So we should all try to be supracondylar champions. And that's what we're going to discuss today.
Okay. You can, yeah.
You can see my presentation?
Yeah, yes.
Great, okay. So, but being a supracondylar champion is not easy. It is very much possible. There are many, even in today's distinguished panel, who are all supracondylar champions, as you will see. So I just want to start off with an anecdote. This is a pediatric orthopedic discussion group that we have, and this is Venkat Das, who works in one of the busiest trauma units in the country. And he puts up this X-ray at 7 o'clock one evening saying, 8-year-old male, what fracture is this? And you're surprised this guy manages 100 supracondylars a year. Why is he asking this question? What fracture is this? But there's a reason. And then Kishore Mulpuri from Vancouver says, that's a low supracondylar, could be a transphyseal fracture. And then that's Indraneel from Texas Children's Hospital. And these are all full-time, gung-ho pediatric orthopedic surgeon. He also says low supracondylar fracture. And then Venkat asks, what's that fragment anteriorly? And you can see a little fragment there, and he's worried about it. And he thinks, there's something not quite right. And then we have the young Turks, Sangeet, who says low supracondylar with a lateral comminuted fragment. And Ishwar, another of our young Turks, says, looks like a type 2 milch with subluxation and rotation. And someone suggesting an arthrogram, CT. And then someone even suggests doing an MRI. And another of our young pediatric orthopedic surgeons, Ishwar from Palakkad, says, look at the medial border. It looks so smooth. So would you have such a smooth medial border if it was a low supracondylar? So he is thinking that this is more of a lateral condyle fracture. And then we have our boss man, Alaric Arujas, saying the capitulum is lined up with the radial head and the whole forearm is translated laterally. So he is starting to analyze this fracture properly. So this is what he's talking about. He's seeing that the whole forearm is translated in relation to the humerus axis. So he says it's either a distal physeal separation with a large lateral fragment. And then Kishore again says there's another possibility, which is a lateral condyle fracture with a dislocated elbow. So we have all of these possibilities, a low supracondylar, a distal humeral physeal separation, lateral condyle fracture with a dislocated elbow, and there is that mysterious piece of bone, which no one is able to account for. And then Premal Naik, who's another trauma king from Ahmedabad, he says, you can get further information by doing a traction film and a GA, or even an arthrogram. And then the next day, Venkat gets back to us and says, it was a low supracondylar, right? So that's what he found under GA, and he has fixed it very well with cross spinning. So that's the olecranon fossa, and then that's the fracture line, and it's going below the olecranon fossa, but it's going across the entire humerus. So correctly, this is a low supracondylar fracture. If it had been physeal injury, then you would have seen the fracture line going into the physis, into the cartilaginous physis. So I think we will call Venkat our supracondylar champion because he has managed it very well. But let's look at how exactly he has managed this properly. He had a good understanding of the fracture type and configuration. He recognized that this was an unusual pattern. He considered the possibility of further investigation, such as CT, MR, and arthrogram, but keeping an open mind all the time. He managed to get an accurate reduction and achieve stable fixation of the fracture. And quite rightly, our friend Professor James Huey from Singapore says beautiful. So that's a very satisfactory result from a rather difficult and unusual fracture pattern. But obviously, all of these people have given their inputs so that Venkat can manage this fracture better. So the one thing he did not do was an arthrogram. This is another example of a low supracondylar fracture that was fixed, and the surgeon then did an arthrogram to confirm that this was not an intra-articular fracture. And the reason we do arthrograms is because the medial side of the distal humerus is cartilaginous and you can't really see it on the X-ray. So you don't know where the fracture line exactly is going. So it's always good to do an arthrogram. And because you have a large medial fragment in a low supracondylar fracture, you should always do a cross spinning of these fractures. So the first challenge for us is to understand the fracture type, and the way orthopedic surgeons understand fractures is to classify them. So there are two main classification systems that we use. First is the Wilkins modification of the Gartland system, and this tells us about displacement of the fracture. So Wilkins tells you whether to fix the fracture. And we also have the Bahk et al. Classification from Baltimore, from Johns Hopkins, Sponseller's unit, that tells us about the fracture pattern. So Bahk tells us how to fix it. And both of them are important if we want to manage supracondylar fractures properly. So everyone knows this. The Wilkins modification of the Gartland system, type 1 is undisplaced. Type 2 is where the posterior hinge is intact. In this, you have two subtypes, A, which is a pure extension type, and B is where there is extension with rotation of the distal fragment. Type 3, as you know, is completely undisplaced, and type 4 is a new type which has been introduced in the last 10 years. And these are fractures that are unstable in flexion and extension. So these are all typically extension type supracondylar fractures, but even flexion type supracondylar fractures can be put into type 4, strictly speaking. So where is the doubt? So with type 1, we know how to manage them. Type 3 and 4, we know how to manage it. There's absolutely no doubt. Type 1 is just immobilized and cast, and type 3 and 4 always require fixation. The type 2 fractures, where the posterior hinge is intact, is where there is doubt at the moment in the literature and among surgeons about what is the best way to manage. So this is Dr. Teddy Slongo's 30-second algorithm. If you have any doubt about how to classify any X-ray based on Wilkins classification. You start in the middle, look for whether it's a complete fracture or not. If it's not a complete fracture, you basically take a lateral view and look at the Rogers line, which is the anterior humeral line. If it goes through the middle of the capitulum, then it's a type 1. If it doesn't go through the middle of the capitulum, or if there is more than 2 mm of valgus or varus fracture gap, then it's a type 2. So if there is complete discontinuity of the bone, then it has to be one of the unstable fractures. And even in this, if there is some contact between the fracture fragments, it's a type 3. And if there is no contact, it's a type 4. And the type 4 fractures are the really unstable ones. And there's a small pearl from Dr. Slongo in the footnote that says, any sign of translation implies that there is lack of bony continuity. So on the AP X-ray, if you see any translation, automatically it becomes a type 3 or a type 4 fracture. So the type 2 fractures, like I said, is the most interesting because these are seemingly innocuous fractures. But when we do long-term follow-up studies, so this is a minimum 10-year follow-up of supracondylar fractures, the authors found that the type 2 fractures have impaired long-term recovery and justify individual consideration in their treatment. This is another paper in the American JBJS, specifically looking at type 2 fractures, and they showed that when a type 2 supracondylar fracture is managed conservatively, there is a good chance that there will be mild cubitus varus deformity and mild increase in elbow extension, indicating a certain amount of malunion. But these are all historical series that look at patients, children with type 2 fractures that have been managed conservatively or with just closed reduction and casting. None of these type 2 fractures used to be managed with a pin. So the question is, are we under-treating these type 2 supracondylar fractures? And this is another study that looked at closed reduction and cast immobilization of type 2 supracondylar fractures. And again, they found that not all fractures that were treated with cast immobilization achieved a good functional outcome. So maybe we need to be treating type 2 fractures more aggressively. So what is the solution? So first is to find out which type of type 2 fracture. So this is a paper from Fitzgibbons et al. So they identified 2 factors. Number 1, if the anterior humeral line, the Rogers line, does not touch the capitulum, then that is one fracture that you need to be worried about. And number 2, if you have a very swollen arm, then probably cast immobilization will not hold the fracture in a stable position. So these are 2 risk factors in type 2 fractures, which makes you think more towards closed reduction and percutaneous spinning. So the traditional teaching was type 2A, the pure extension type, was manipulation and casting. But within type 2A, we have now seen that there are 2 subtypes. First, where the anterior humeral line is touching the capitulum, and the second, where the anterior humeral line is not touching the capitulum. And both of them are type 2A fractures because it's pure extension type. There is no rotation. So we have 2 subtypes of 2A fractures. So the traditional teaching needs to be revised. So let's look at the case of the 6-year-old girl who fell on her outstretched hand and presented to us with this initial X-ray. And I drew the anterior humeral line and found that it was touching the capitulum. So I said, well, if it's touching the capitulum, I'm going to treat it non-operatively in cast, in flexion. And this was a week later when we did the check X-ray, we had found that the fracture had extended further and it was no longer touching the capitulum. So this girl went on to require closed reduction and percutaneous spinning. So whenever you have doubt about whether the anterior humeral line is touching the capitulum or not, always get an X-ray at 5 to 7 days post-injury to see if there is any further displacement. So this is actually a type 2A2. Type 2B, there is absolutely no sort of argument in the literature. All of these are now managed with closed reduction and percutaneous spinning because whenever you have rotation, the distal fragment can always go into varus because of the anatomy of the supracondylar area. So this is an example of a child who has a type 2B fracture that was managed by closed reduction and percutaneous spinning. and she went on to do well. The other factor which I frequently find is the difficulty in getting a true lateral view. This is a 3-year-old boy who actually came to us during the lockdown, very high profile family. And the radiographer sent me this initial X-ray, and I was not really happy with that lateral. It looked okay, but not enough to satisfy me. So I told him, take another lateral, because the capitulum was overlapping over the ulna. And usually I don't like to see the capitulum overlapping the ulna. That tells you that it is an oblique X-ray. So this is the take 2 that the radiographer sent me, and I still wasn't happy because again, you can see that the capitulum is overlapping on the proximal ulna. So I sent my fellow, I told him, hold the arm properly and flex the elbow. And that's the actual true lateral view. And you can clearly see that there is rotation. So you're seeing a AP view of the distal humerus on a lateral X-ray of the elbow. And clearly this is a type 2B, extension type with rotation. And this should be managed operatively. So we took him to the OT, found that there was significant rotation. We just internally rotated the proximal fragment to correct that, and he underwent closed reduction and percutaneous pinning. The other type in the type 2 fracture is the varus impacted type 2, where there is medial comminution. And these are also very, very innocuous looking, but they actually have a high rate of complications. So let's look at this 3-year-old boy. Again, he's actually a type 2A. The anterior humeral line is going through the middle of the capitulum. But if you look at the medial cortex of the distal humerus, you can see that there is some comminution and a varus collapse. So he was treated in plaster by a general orthopedic surgeon. I think you can't really blame him because it's a very innocuous looking fracture. And that is the X-ray at 6 weeks. And this is the clinical appearance at 6 months. You can see that he has gone into cubitus varus, and that is because of the unrecognized medial column comminution. So there is one paper which is published by Kish et al., which shows that if you do want to fix a type 2A fracture, the type 2A where there is extension and it's not touching the anterior humeral line, the anterior humeral line is not touching the capitulum, then you can manage with just a single pin, because these fractures are pure extension types and they are rotationally stable. So, but in order to get away with a single lateral pin, you need to have near anatomic closed reduction, and you should get a bicortical lateral entry smooth pin. And they also encourage you to check dynamically under fluoro to make sure that the fracture is entirely stable. So there is a possibility that we may be moving towards a single lateral entry pin to maintain the type 2A fractures from going into further extent. So for 2A fractures, we need to recognize that there are many subtypes within this. The 2A1, where the anterior humeral line touches the capitulum and the arm is not swollen, you still can manage it in cast, but you need to take an X-ray at 5 to 7 days. The 2A2, where the anterior humeral line is behind the capitulum, or you have a swollen arm, better to do a closed reduction, percutaneous pinning primarily. And the 2Bs, the extension with rotation, there is no question, they require fixation. But the trend is towards closed reduction and percutaneous pinning of all type 2 fractures. So the other classification system that I was talking about was the morphological classification that looks at the fracture pattern. And this was published in 2008, and this is from Sponseller's unit, Johns Hopkins in Baltimore. And they looked at subtypes in terms of the fracture line, not in terms of displacement, but in terms of the fracture configuration. So they identified many subtypes. The commonest is the transverse, which is the typical transverse fracture. You can have a lateral oblique fracture where the fracture line exits on the lateral cortex proximally. You can have a medial oblique fracture, or you can have a high fracture where it's above the olecranon fossa, but still in the metaphyseal region of the distal humerus. On the lateral view, you can have a typical sagittal pattern or a high obliquity sagittal pattern. And each of these fractures behaves differently when they are stabilized. So they advised a more nuanced or customized approach depending on how the fracture line was in the distal humerus. But thankfully, the vast majority of the coronal subtypes are actually typical transverse fractures, accounting for more than 90% of fractures or lateral oblique fractures. The medial oblique fracture and the high fracture constitute less than 10% of all supracondylar fractures. In the lateral view, 60% go straight across, and 40% of fractures in this particular series were found to be found to have high sagittal obliquity. So, how does this affect our pin construct? In typical transverse or lateral oblique fractures, you can get away with lateral only pinning. If it is a medial oblique fracture, if it is a high fracture, or if there is sagittal obliquity, these are all potentially unstable fracture patterns if you do only lateral only pinning. So you need to do medial pins or you need to do cross pinning. So to simplify this, if it's a typical transverse fracture or if it's a lateral oblique fracture, you can get away with lateral only pinning, and all other subtypes would be better off with cross pinning. And that kind of makes sense. So you can imagine that if you have lateral only pins going across these two fractures, that would be quite good. But medial oblique fractures or high fractures obviously need cross pinning. So, so we saw that Venkat Das was very particular in achieving accurate reduction. And the big question in every orthopedic surgeon's mind is, can I get this reduced closed? Because opening a supracondylar fracture is fraught with difficulty and complications. But the good news is we can achieve closed reduction in most supracondylar fractures. So how do we do that? We follow a very specific reduction sequence, as Skaggs has told us. We do traction in 30 degrees of elbow flexion to restore length. Then we correct translation, then rotation, and lastly extension. So it's very important to follow this particular sequence when you're doing the reduction. And it's also important to check the reduction. So in addition to the AP and lateral view, you should get these so-called column views by looking at the fracture pattern in 45-degree oblique planes. So you know that the medial and lateral columns or medial lateral cortices are accurately reduced. So what if a supracondylar fracture will not reduce closed? So then we have to resort to various augmented closed reduction techniques. And these techniques are very useful in preventing an open reduction. So you can do a joystick or a derotation wire. There is Kapandji reduction. You can do an anterior mini open reduction, or you can do milking of the brachialis. And we will look at these in reverse order. So this is a 3-year-old boy who has a type 3/4 supracondylar fracture. And you can see the large ecchymosis. And you can see that there is puckering of the anterior skin. And this shows that there is some tenting of the proximal fragment through the brachialis muscle. So in these cases, what we do is a milking maneuver of the brachialis. We just milk the brachialis from proximal to distal in order to deliver the fracture away from the brachialis. And this is milking the brachialis. And that is after we have milked the brachialis, you can see that there is no more puckering of the skin. So this is an important maneuver that you need to do prior to starting your reduction sequence. So this is a 6-year-old boy. You can see that I'm having difficulty because again, AP of the proximal fragment, lateral of the distal fragment. So in these cases, what we can do is go lateral to the biceps, make a stab incision, and I use an artery forceps to basically push the fragment back. I already have inserted a K wire into the distal fragment, ready to advance it. So as soon as I've got it reduced, my assistant advances it into the proximal fragment. But it's always important to check the pulse and make sure, because you're going in the anterior aspect of the elbow, and one needs to make sure that there has not been incarceration of the brachial artery at the time of the reduction. So always check the pulse and make sure you have a biphasic waveform. So Viraj, as another way of doing the same thing, so this is a 9-year-old male who presented a few days after a supracondylar fracture, and there was 3 attempts of closed reduction. So here anybody would try to do a open reduction. Instead, what Viraj did, what I do with the artery forceps, Viraj does it with a suction tip with a blunt end, and the suction tip has the added advantage that you can evacuate the fracture hematoma, you can reduce the amount of tension in the compartment, and the reduction also becomes easy. So using a blunt suction tip, a metal suction tip, I think is certainly worth considering, and you can also use it as a joystick to achieve reduction. And you can see how Viraj has actually marked the neurovascular bundle very clearly on the patient so that he stays well away from it. So this is the reduction sequence. You can see the sucker tip, how it's pushing on the proximal free fragment, whilst the assistant reduces the fracture, and then you pass the wire across. And you can see again, Viraj also in the last slide, he has got the wire ready, waiting to be passed across the fracture. And then because this was a high supracondylar fracture, he chose a cross pinning technique, and that went on to heal very well with good range of movement and good function. So the other thing which can be done is Kapandji reduction, and this is very similar to what we would do with the distal radius fracture. This is a paper from Taiwan. The only downside is that you need to do it in the prone position, and the sequence of Kapandji reduction is you just do it interfocally, and then you lever the fracture down, and then you pass the wire across to the anterior cortex. But I have found this that I can use this Kapandji technique even in the supine position. You need to make a few modifications, and I usually use it for the final reduction in a high sagittal fracture, just to get that final reduction to push the fragment back into place. And the way to do this in the supine position is to put a big pump, get the elbow off the table so that you have enough room to put your K-wire from. So you basically put it through the triceps and then lever the fracture into place. So this can be done ideally in the prone position, but you can also do it in the supine. So this is another way, another scenario. This is an 8-year-old who was referred 1 week after open reduction and percutaneous spinning. So this was the reduction and fixation achieved by the index surgeon, and after a week they came to me, and you can see that there is more than 50% translation of the fragment. There is loss of reduction, and the pins were also loose and backing out. So that's the intraoperative picture. You can see that the open reduction incision is actually starting to open up because of the displacement. And in this scenario, where you have a very unstable fracture pattern, you can put a wire in the proximal fragment that acts as a joystick or a derotation wire, and that gives you control over the proximal fragment, and you can actually use the forearm to manipulate the distal fragment into place. And this was a lateral oblique fracture, so I was able to get away with 3 lateral pins, and this child went on to do fine. So augmented closed reduction helps you to avoid an open reduction, which in most instances, in 9.5 out of 10 cases, it's unnecessary. If you want to open it, use the anterior approach through a transverse elbow skin crease incision, because that puts you directly onto the front of the fracture where the reduction needs to be done. And by all means, at all costs, you have to avoid a posterior approach. It gives the worst cosmetic result, and it causes a lot of stiffness. What about the so-called almost perfect reductions? This is where you've got 95% reduction, and you're thinking, do I accept this or do I have to go for 100%? So minimal rotation is acceptable in young children, and up to 1/3 humeral width translation is also well tolerated. These remodel very well, but the important proviso is that you must get stable fixation. So long as you have stable fixation and good pin configuration, minimal amount of rotation is okay. So this is again a very small child, a 3-year-old with a type 3/4, a lot of ecchymosis and soft tissue injury. We didn't want to do excessive manipulation. We got an acceptable reduction with a little bit of residual rotation. We pinned it in place in a stable manner with parallel pins. That is the post-op X-ray at 6 weeks, showing good remodeling and good return of function and good cosmesis. But you cannot take any chances in the older child. So this is an 8-year-old where a surgeon at an outside center did cross pinning, but I don't think the pins were really very stable. Even though they have tried cross pinning, you can see that one of the medial pins is actually going through the fracture site. And that resulted in some residual translation, a lot of remodeling, a lot of anterior bone in the humerus, and the child had a flexion block. He was not able to flex beyond 80 degrees. And because it's his dominant hand, he had problems, eating food. So one needs to be very careful with accepting suboptimal reductions in older children. And if you're going to accept a slightly less than perfect reduction, make sure that your pin configuration is extra stable. So moving on to flexion type supracondylar fractures. This is Ashish Ranade's case, a 9-year-old child, typical flexion type supracondylar fracture. The books say all flexion fractures require open reduction and internal fixation. This is the traditional teaching. So the other thing about flexion fractures is a particular type of nerve injury is very common, and in the interest of time, I'll reveal the truth, which is the ulnar nerve. And the ulnar nerve is at particular risk, not only during the time of the fracture that the ulnar nerve may be stretched and undergo neuropraxia, but also during reduction. And when we reduce these flexion type supracondylar fractures, there are documented reports of the ulnar nerve getting incarcerated in the fracture site. So it's very important to do a pre-op clinical examination. So these are intra-op C-arm images, and the traditional approach is to do an open reduction and K-wiring, but we prefer to do a modified closed reduction technique. And what Ashish has done is a so-called trans-olecranon pin. So you basically bring the two fragments roughly together and put an axial pin through the olecranon that basically holds the distal fragment in place, and it helps you to then tweak your reduction and get the final pin configuration in place. And this is post-op X-ray showing satisfactory maintenance of alignment and a good clinical and functional result. So there are two augmented closed reduction techniques which have been described in the literature. This is the one I use. It was described in the JPO-B, where you use a rolled up towel which is directly placed posterior to the fracture, and you apply a push on the forearm, and then you pull up on the arm and you line it up and you pass your pins. And the trans-olecranon pin, which is described by Green, is the one that's favored by Dr. Ranade, which is what he demonstrated in this case. But for all of these fractures, there is a learning curve and you need a trained assistant with you. These are not fractures that you can manage closed if you are a single surgeon. So for flexion type, you have to always look for ulnar nerve dysfunction. You can anticipate difficulty in achieving a closed reduction, but you have two methods at your disposal, the push-pull technique and the trans-olecranon pin, which can help you achieve a closed reduction with percutaneous pinning. But flexion type supracondylar fractures do have a higher complication rate compared to extension type, and it's always worthwhile mentioning this to the parents. So what do we mean by stable fixation? The reason I said 2 decades of experience is because this was a landmark paper which was published from Southampton in the year 2000, exactly 20 years ago, O'Hara and Clark, and they showed 3 factors which really transformed the outcomes following supracondylar fractures, type 3 supracondylar fractures. And that is, number 1, there should be a senior surgeon in the operating room. When you manipulate, you should always pin. There is no room for closed reduction and casting in supracondylar fractures. They should always pin, and you should use an adequate thickness pin, minimum 1.6 millimeters, ideally 2 mm wire if there is enough room. And the other major improvement was by Skaggs and co-workers, who introduced the lateral entry technique, the lateral only pins. And the advantage of the lateral only pin is to avoid the risk of an iatrogenic injury to the median nerve. And the 4 points that he mentioned was there should be adequate separation of the pin sites at the fracture site to give you rotational stability. You should engage the medial and lateral columns proximal to the fracture. And I'll show you an illustration of that. And you should have sufficient bone engaged in the proximal and distal fragments. And you should always insert a 3rd lateral pin without hesitation if there is any question about stability. So that's a typical transverse fracture. That's the proximal fragment. You divide it into medial and lateral columns. And when you put your parallel lateral only pins, you should make sure that you have the pins. 1 pin should be there in each of the 2 columns of the proximal fragment. and there should be adequate pin separation at the fracture site. Having said all that, anyone can have a bad day at the office. This is a 6-year-old boy, had a simple fall and type 4 supracondylar fracture, severe soft tissue trauma, but thankfully neurovascularly intact. That's what I managed to achieve. That was the best reduction and fixation I could achieve. You can see that the lateral pin has not engaged the medial cortex. Reduction was a struggle, fixation was suboptimal. He managed to heal well and remodel, good range of movement, but you can see that he has got slight amount of cubitus varus and he has also got internal rotation. So even with 20 years of experience, there are days when things don't go your way and you may have to sometimes accept a suboptimal reduction. Moving on quickly to nerve injuries, these can happen from the fracture itself and the incidence is between 5 and 10%. And we can also cause nerve injuries and the risk of that is about 3% from a large meta-analysis of 5,000 supracondylar fractures. So this is a 5-year-old boy, typical type 3 supracondylar fracture, no neurovascular deficit apparent on examination, and I personally examined this child. Within 6 hours, I managed to get good reduction in percutaneous pinning. 24 hours later, mother calls me saying, painkillers are not working, he's got shooting pains in the forearm and child is not able to sleep. So at 1 week follow-up, he's got a pointing index finger, he's got median nerve paresthesia, the pain is not getting any better, so we explored the nerve. I did a direct anterior approach and found that the median nerve was incarcerated. Basically, the proximal fragment had just tagged the epineurium and it had pulled it in when I reduced the fracture. So I just released the epineurium, the nerve pain resolved very promptly, and he got complete recovery of the nerve within 6 months with full range of movement. So he had no sequelae at all because I was able to react early. I bit the bullet, I went in, explored the nerve. So, and this is exactly what the literature says. If a patient has neuropathic pain, and if there is a complete lesion with sympathetic paralysis, or if there is a progressively deepening nerve lesion between 8 to 12 hours of surgery, or if there is coexisting ischemia, then there are indications for early exploration of the nerve. This is the case from Viraj Shingade, 7-year-old male. It was fixed elsewhere, and by the time the child came to Viraj, he already had a ulnar claw. So Viraj had to explore, and he found that the medial pin was actually skewering the nerve. So he was able to remove the nerve, pin away from the nerve and followed a standard protocol because it was already 2 weeks after surgery. There was probably enough stability at the fracture site. So child got a good result, both functionally and clinically. So with regard to nerve injuries, the surgeon must examine pre-op every child with a supracondylar fracture. Do not ask your juniors to shift the child to OT and then you go in when the child is already anesthetized. That is not acceptable for supracondylar fracture. You must go and examine the child preoperatively. Watch for nerve function even after the most routine pinning of supracondylar fractures. Neuropathic pain is a very sensitive sign. Be vigilant if you want to use a medial pin. Take your entry more anteriorly, palpate the nerve with your thumb, keep the elbow extended, and do not ignore if the patient complains of severe pain. And if in doubt, don't sit on our ego. We have to explain to the parents, it means having another operation. It's always a difficult conversation, but if you do early exploration and release or repair the nerve, it gives good results. So the last slide is on vascular compromise, and 1 in 10 supracondylar fractures will have some form of vascular compromise. The 2 things we look at are pulse, and if you have a handheld Doppler in your hospital, that gives you good additional information. Unfortunately, pulse oximeter is not reliable because pulse oximeter tells you only about skin perfusion and it does not correlate with muscle perfusion, which is what we are really interested in, because what we don't want is to have muscle ischemia and compartment syndrome. If there is an associated nerve lesion, the literature strongly supports early exploration because this is more likely to be either an incarceration of the artery within the fracture site or a complete transection of the artery. And another thing recently in the literature is that the typical 5 Ps of an arterial injury have been replaced by the 3 As. And the 3 As are anxiety, increasing apprehension, apprehension is when the child doesn't want to move the fingers, and increasing analgesic requirements. So these are the 3 A's which in a child indicates worsening muscle ischemia. And if you have the 3 A's, you have to explore early. So in a child with a pink pulseless hand, do not discharge them, keep them in hospital for 48 hours post-op to monitor it. In case people are interested, Sandeep Patwardhan has an excellent video journal club on the pink pulseless hand, which is again on OrthoTV. And it's just 15 minutes and it gives a beautiful overview of how to manage the pink pulseless hand in an evidence-based manner. So if you want to be a supracondylar champion, you need to be able to classify supracondylar fractures beyond the typical Gartland classification. You have to be able to reduce these fractures, even the difficult ones, without opening them. You have to achieve stable fixation of them. Also, the atypical fractures have to be stably fixed, and you have to be able to address the neurovascular issues. I want to honor my teachers and my OC friends. We are a large group of pediatric orthopedic surgeons who are passionate about supracondylar fractures. I want to make special mention of Taral, who has a particular passion for teaching about supracondylar fractures. And of course, thank you to Dr. Shiv Shankar for giving me this opportunity to talk about managing supracondylar fractures. So we'll move to discussion. Thank you.
Thank you very much, Jayant. That was a wonderful exposure. I asked all the panelists to unmute and start their questions they have, but I start with one of the questions I have. You said that 1/3 translation in children is acceptable. Till what age? Children means what age? Because that is also very important. You can stop sharing the screen. Yeah.
Yes. Right. So I would say 5 or 6 years would be the most I would accept. And by the time they get to 7 or 8 years, these are bigger children. And the problem is that the elbow is a very slow growing joint and it doesn't remodel very well. So, and there is also this anterior bump that you get sometimes blocks flexion. And because Indians, we eat with our fingers, so we need full flexion of our elbow in order to be able to do a normal function. So in very young children who are younger than perhaps 5 or 6 years, I might be tempted to accept slight degrees of malrotation, but the others can respond.
Yes, Rajendra.
I think I would. Yeah, my question is, if a patient we are trying with the manipulation under GA, and the reduction is not coming, either there is rotational malalignment or displacement, or the bone again and again goes on shifting. So what is your threshold for going for open reduction? And if required to go for open reduction, what approach would you select in the current scenario?
So here you mentioned 2 separate problems. First is that the fracture itself is not reducing. So you need to analyze why is the fracture not reducing. If you are able to get a springy reduction, as in you are able to bring the 2 fragments together, but instantly it goes away, that means there is something interposed between the fracture. So typically that's the brachialis, though it can also be the artery and the nerve. So one needs to be very careful, particularly with posterolateral displacements. So the 2 techniques I would use in this, number 1 is milking the brachialis, and number 2 is making the small anterior stab incision lateral to the biceps, which I showed. You can either use an artery forceps just to get the brachialis, just to push the brachialis away from the sharp edge of the proximal fragment, or like Virat showed in this case, you can use a blunt sucker tip. And that again, these 2 techniques are extremely useful. So rarely do we have to actually open a supracondylar fracture. We use mostly these augmented closed reduction techniques to try and get the reduction in the first place.
Okay, thank you.
Yeah.
So, do you have any comments?
Yeah, till when you will be doing attempting close reduction? Say if the patient comes 5 days, 10 days, 2 weeks, already somebody has treated. What is your threshold for deciding to go for open reduction or close reduction?
Again, that's age dependent. In children under the age of 5 or 6 years, they form callus very, very quickly. Within a week, there is soft callus and you can start to see callus on the X-ray. So in the presence of callus, I would be reluctant to intervene in a supracondylar fracture. If there are minor degrees of displacement, I would accept it. And in case they develop a malunion, I would be inclined to go and treat it later. The maximum I've ever opened a supracondylar was at 2 weeks, but that again was because there was a neurological injury and I was opening the supracondylar fracture more for the neurological injury rather than for the fracture itself. So much beyond a week to 10 days, I would not really make any forcible attempts at reduction or fixation because there is a very high risk of heterotopic ossification, of stiffness, and ultimately it's not enough if we produce a perfect looking X-ray. What we want is an arm that moves well, and even minor degrees of malunion, it's only a cosmetic problem. It's well tolerated, but a stiff elbow is poorly tolerated. And because of our intervention, if the child develops a stiff elbow, then I think we will have done the child a disservice. So I think as surgeons, we need to understand our limitations. Much beyond a week to 10 days, I think one needs to be extremely careful and thoughtful before going into reduce or fix supracondylar fractures.
Yes, Mandar.
Yes, sir. I have a couple of questions. One is my own question, which is, do you give or does your anesthetist give blocks for your supracondylars preoperatively? No. Is it a rule that you just never ever allow your anesthetist to give a block preoperatively or something of that sort?
Yeah, I generally do not use nerve blocks because I'm very particular, particularly after my median nerve incarceration episode that really brought to light the fact that even with a very ordinary looking supracondylar fracture where you've got perfect reduction and you're very confident about yourself, but just one case like that can really knock your confidence. So you start to become more cautious, more careful, and more mindful of what can happen. So for younger surgeons, I think you really have to be very, very confident about your post-op neurological examination. And before you discharge the child, you should make sure that the child is moving the fingers. And I would insist that the treating surgeon should go and examine the patient post-op. It's not enough that you ask your resident to go and tell, and the resident calls you and says, "Sab kuch theek hai, sir," and then you say, "Okay, discharge." And then they come back a week later with a claw hand, and then you'll be kicking yourself. Because the consequences of that are then you have to take the patient back to OT, and it's a very difficult conversation with the parents. And you are making what is potentially if the child is under the same admission, if you pick up a very early subtle claw hand, you can just say, "I'm just going to take this child back just to change the plaster," or something you can tell, and you can just quickly change your pin configuration or something. But once you've discharged the patient, in the Indian context, to readmit the patient to hospital and reoperate on them, I think is an extremely difficult thing to do. And it's a very embarrassing situation for us as surgeons. And most importantly, it's not, we are not doing the best service to the child. So I think that pre-op and immediate post-op clinical examination, I think should be done by the most senior surgeon who has actually operated on the child. And you should document it in the notes very clearly that you've examined all three nerves, and you should say that all three nerves are intact pre-op and post-op. Right. So in case something happens later, then you can at least work out what happened when, how did it happen, or it helps you to retrace your steps.
Yeah. Second question is coming from Professor James Hui, who is listening to your lecture from Singapore. So he's asking, what is your preference, whether you want to put 2 mm pins or 3 1.6 mm pins? So are 2 slightly thicker pins better than 3 slightly thinner pins?
So there I look at what is the width of the fracture I have.
Okay.
So if I have a fairly wide fracture width, I would prefer to put 2 big pins.
Okay.
If I have less width, and if I put 2 big pins and they are not enough, there is no room to put a 3rd pin.
3rd pin, yeah.
So the narrower the fracture width, so the higher the supracondylar fracture, the thinner my pins, because then I have enough room to put more and more pins in different directions. So I can diverge the pins, I can add an extra medial pin. So if you have a higher supracondylar fracture, I would generally add an extra medial pin. And if you've already put two big stout 2 mm pins across the fracture, then your third pin will always go and hit the 2 pins. So the lower the fracture, the bigger the pins can be. The higher the fracture, the narrower the pin should be. But I would never go below 1.6. 1.6 is the minimum pin I would use, and 2 mm is the maximum pin. I had a bad experience once putting a 2.5 mm pin in an older child, was about 10, 11 years old, and it was not a happy experience. So so it's always between 1.6 and 2 mm.
Yes.
If you have a 1.8 pin, that's really good, because it helps you to
balance both.
So balance both. I always have a 1.8 pin in my hand.
Right.
Okay. Before going to Ashish or Viraj, I have got a question from Dr. Swapnil Kotadia from Sholapur. What is the treatment for anterior bump in case of malunited fracture with restricted elbow flexion? Do we need to recreate the anterior fossa for radial head and coronoid also? This is the question.
Okay, that's a very good question. In fact, one of the cases I showed, the older child who had the malunion with the translation and an anterior bump and lack of flexion, I waited 3 years. So I waited 3 years after the fracture, waiting for the elbow to grow and for that bump to gradually move away from the trochlear fossa. And after 3 years, there was absolutely no improvement in flexion. So I was worried about whether he might develop some kind of secondary triceps contracture or a capsular contracture. So I actually did a procedure to go and shave away that anterior bump, and thankfully he got enough flexion, about 120 degrees flexion, to be able to get on with his functional activities. But particularly in a younger child, so this was an older child. So in a younger child, if you're say 3 or a 4-year-old, my experience is that bump gradually just grows away from the trochlear fossa, and you don't have much problems with getting flexion back. So I would wait at least a couple of years. I would wait at least 2 years before doing any sort of bumpectomy.
Yes, you have done only bumpectomy, or you have recreated the anterior fossa for the radial head and the coronoid also.
But it's not; those are not easy operations, because this is abnormal anatomy, and all you see is just a mound of bone. So how do you create? So where do you start? So these are all very complex operations, and not complex but fiddly operations, and they are not they're not satisfying operations. You are only doing these operations because you're forced to. And the problem is the original sin that happened is the initial treating surgeon. So that person, if they had just been a little bit more thoughtful, then all of this downhill slide of poor function could have been avoided. And you always end up gritting your teeth thinking, if only they had spent an extra 10 minutes fixing this properly, I wouldn't be sitting here trying to remove bone from the anterior part of the humerus. So these are not happy situations. We should try to avoid them at all costs.
Okay, let's go to Ashish Ranade. Ashish?
Yeah, so what's your protocol for the type 2s which you are going to treat non-operatively? You put them in a cast, splint, how frequently you follow them?
So all type 2s go into cast in 90 degrees of flexion. And I personally supervise to make sure that the cast is in 90 degrees of flexion, because children always tend to extend as you put a cast, particularly when they're awake. Putting a cast when they are asleep in OT is different, but when they are awake, they always tend to extend. So I always make sure that they are at 90 degrees of flexion, number one. Number two, I subclassified 2A into 2A1 and 2A2. In my book, the 2A2s, where the anterior humeral line does not touch the capitulum, they all get primary closed reduction in percutaneous spinning. The type 2Bs get a primary closed reduction percutaneous spinning. The 2s where the anterior humeral line is touching the capitulum, they will get an X-ray, a check X-ray, a true lateral view at 7 to 10 days. At 5 to 7 days. They will get an X-ray at less than a week to make sure that they don't extend. And I showed one of the examples where it was, the humeral line was touching the capitellum, but a week later, it's just drifted back. So these, every type 2A fracture, if you're not fixing them, they have to be watched very closely. And you should get a true lateral X-ray, and if necessary, remove the cast and get an X-ray out of plaster. But be absolutely sure, because at 5 to 7 days is the last chance you have to do anything significant about it. If you have missed that 1 week opportunity,
Yes.
and it's going to start healing in extension, and then you've lost, you missed the boat. So you've got to really pick them up at a very early stage, and if you treat them appropriately, then you get a perfect result, and you can, you really feel like a champion.
Yes, we have a question from Dr. Narayan Swami from Bangalore only. What's your indication for medial pin, and what are the tricks to avoid ulnar nerve injury after fixation? So I do stress test to make sure that the fixation is stable. So
absolutely. So I think that's a very good point. I frequently do this, where I take a true lateral cross table lateral, and then under live screening, I just flex and extend the elbow to make sure that the fragment is actually absolutely stable. If I have any doubt at all, I'm a lateral pinner. I very rarely use a medial pin. I would not hesitate to use a third lateral pin. The only time I would use a medial pin is according to the BAHK classification, the Baltimore classification, if it is a medial oblique fracture or if it is a high supracondylar fracture. If it's a medial oblique fracture or a high supracondylar fracture, I would add a medial pin, because 2 lateral pins will not stabilize the fracture adequately. So you have to use, for every fracture, you have to use both classification systems, both the Wilkins classification and the Bahk classification for every supracondylar fracture, except the type 1s. The type 1s are fine. But other than, if there is any displacement at all, I think you need to look at fracture morphology, not just fracture displacement. And I think that's a key takeaway point from this talk.
Yes, Viraj, we'll go to Viraj. Any questions?
Yeah, Jayant, did you have any kind of difficulty particularly for the higher fractures and very long oblique fractures? Because it is very difficult to put the pin from the second cortex, it doesn't go. So do you have come across this kind of difficulty, and what was your mode of treatment for that?
So absolutely. So these are, the high fractures are difficult to reduce and hold the reduction, because you will get the reduction, but by the time you get the pin to the bone, it's kind of drifted again. So here, 2 things have really helped me. Number 1 is an assistant. So whenever I have a difficult supracondylar fracture, I always have an assistant. So I'm lucky enough that I have a full-time associate who's also a pediatric orthopedic surgeon working with me. But if you are an adult orthopedic surgeon who does a lot of pediatric trauma, do not hesitate to invite your best friend, another orthopedic surgeon who happens to work in the same hospital. Invite them, and then it becomes a really fun experience, because there are 2 of you there. Your tension goes away. You've got another person thinking and helping you out, and they are a trained pair of hands. So you don't have to tell them what to do. They know, so they will be constantly just tweaking and helping you. So it's a really fun experience to have another trained pediatric orthopedic surgeon with you.
4 hands and 2 brains. 4 hands and 2 brains.
Nothing like it. Nothing like it. It's it's a really wonderful experience, and a lot of times you feel like giving the entire surgeon fee to that person, because you've just loved the experience so much, and that other person has added so much. So coming to the more important point, use the derotation pin. So use the put a transverse pin well away from the supracondylar area into the proximal fragment, and that gives you a firm hold on the proximal fragment. So then using the forearm, you can manipulate the distal fragment, and you can pull the 2 and keep them together for that fraction of a second that you need to pass the pin. So those are the 2 things I feel would help you to maintain the reduction until you get the pin in place.
Jayant, the lumpectomy, what you said, you tried in few patients. Was you really happy? Because the parents, what they expect, the good range of movement.
No, you never get full range of movements with that. Has that been your experience as well?
Yeah, I couldn't get the good range of movement. To some extent, maybe 30-40 degree it improves, but it doesn't give the good full range of movement. So that is there.
See, the main problem here is extension. Why don't we remove a wedge until and get a flexion? Because I have done in a few cases that, and the patients were happy.
No, it also, I feel, depends on how did the child end up there. So if it was a particularly poorly reduced fracture and there was a lot of surrounding callus, a lot of remodeling around the humerus, so the whole anatomy, as we know, elbow is the most complex joint in the body. It's a trochogangliomoid joint, so biomechanically it's just a total mess. And a lot of times we don't understand the actual intra-articular anatomy of the elbow, how such elegant movement is possible. So I feel that after supracondylar fractures with malunion, there is some disruption of the soft tissue and the bony anatomy around the elbow. So trying to accurately reconstruct it back to normal, I feel is, I would echo Viraj's sentiment that these are not very satisfying operations, but you do them, just to get the child back to some sort of functional range. And that is possible, I feel.
Chandak, sir?
Yeah,
Chandak, sir,
but they have hyperextension, because that is also equally a main problem, because the right hand is not coming to the mouth for eating, and they got a very bad hyperextension. So I try to do a wedge resection of anterior part, and I fixed with KVS, and I should search and show you some of my cases.
Yeah, no, that's more of the supracondylar osteotomy, which I feel is okay. But I mean, in the ones where it is purely because the trachea is going and impinging against.
Not that good. Yeah, instead of lumpectomy, correcting angle is much more better.
Sir, any experience? Sir?
Yeah, the radiological bump goes away, the movement remains absolutely same. So we just have to then counsel them, go on doing physiotherapy and see me after 6 months, 1 year. So
my experience has been similar.
Last question, Jayant. The case you told that the nerve was involved, at a time reduction. So how was, difficult to counsel the parent? Because I think that is one of the very important part. Because the case which the colleague referred to me, nobody does it deliberately. I fully agree that, but it is, I think it is the onus lies on the senior person to counsel the parents in a very nice manner that it can happen because the fracture configuration is like that. So what was your experience?
So this particular case was the relative of my colleague in a children's hospital, and he had given this huge build-up about me, saying I'm the best pediatric orthopedic surgeon in 500 miles and all that. So going back and talking to the family with my tail between my legs was one of the more humbling experiences of my life. And that really, those experiences really, make you feel more human, I suppose, and keep you well grounded that the fracture is always the boss and you have to listen to the fracture. And it teaches you a lot of humility and teaches you a lot of common sense, and not to get high opinion of yourself, because even with the best skill, and that was the last case I showed, that there were 3 pediatric orthopedic surgeons in that room, me, my associate, and my fellow. So there were 3 pediatric orthopedic surgeons in the room, and we had every single technique and equipment that you could possibly imagine. There was absolutely no limitation. I cannot give one excuse for why I didn't fix that fracture properly. Not one excuse. I even had plenty of tea, coffee, whatever you want. I was there, and still it went wrong. So what do? So you just have to accept that sometimes you are human, and these things can happen, but you learn from it. You learn from these experiences, and hopefully it will make you a better surgeon.
Yes, Rajendra?
Yeah. What is your usual policy? You keep all KYS percutaneously out, or you do cut, bury and bend? No cut, bury and bend inside?
No. I keep them out and remove them in the OPD at 1 month. And this is another point. I've seen some adult surgeons removing K-wires under GA. And I feel this is completely unnecessary. You can easily, with a little bit of, a distraction of the child, you can do it. And there is a lot of concern these days about giving repeated general anesthetics to young children. They seem to have some sort of long-term cognitive deficit, etc. So it's a developing area. So you want to try and avoid the number of episodes of general anesthesia in children. And I think you should pull these pins out in the OPD. You should not take them back to OT for removing pins.
Yes. Dr. Narayan Swami has asked a clinical situation. 6-year-old child comes with type 3 supracondylar fracture after 15 days. What's your protocol?
Treat it in plaster.
Okay. Just
put it in plaster.
Let the fracture consolidate in the same position.
Yeah. Just leave it alone. Don't do anything about it. Tell the parents that there might be a risk of malunion, but because there is a lot of growth left, we have to see. And even if there is malunion, it might just turn out to be a cosmetic deformity. Child may end up with good function, and then after a year, 18 months, once it's all beautifully remodeled, you can go back and do a very well-planned French osteotomy or any sort of supracondylar osteotomy of your choice and give a beautiful cosmetic and functional result. The wrong thing to do would be to go in at 2 weeks when there is soft callus there. The whole place is bloody. All the anatomic planes are all blurred. I've been in that sort of situation before. And to any surgeon listening to this, I do not recommend it. It is the wrong time to go in and do anything to a supracondylar fracture because you end up with a lot of swelling post-op and it is not a happy experience. So at 2 weeks, type 3 supracondylar, I would not do anything.
Okay. Yes,
That's
Mandar.
just my experience, but there are 3 other pediatric orthopedic surgeons in the, listening to me. So I would welcome their inputs, whether they would do anything different.
Yeah, Jay, I would agree to a great extent with you, but I would still go ahead for the assisted reduction, till maybe 10, 12 days or maybe, and if parents are sitting for the anatomical reduction or they want a good outcome, I would still go ahead for the open reduction, maybe in between somewhere around 12 to maybe 18 days or 20 days, but not after 21 days. And
okay.
If you see the paper by the Lar and Mann, I think that is one of the only paper in literature has a huge series of neglected presented supracondylar humerus, and surprisingly, they operated even after 2 to 3 weeks even after that, and there was very less chance of myositis. They are not reported myositis in the series, So that is very surprising fact.
So what I find whenever I do these difficult operations, which are described in the literature, that particular surgeon has gone through a huge learning curve over a long period of time. And they have so many nuances which are not really put down on paper. So I think if you want to do such operations, you have to go and see those surgeons operating. You have to work with them. You have to see them doing the operation. What are all the little nuances that they are using? What is the post-op protocol? What are their inclusion, exclusion? What are their indications? And they will have a very nuanced approach. So just by reading a paper, I don't think it's possible to recreate the results with these very technically demanding operations. So, what I am doing is the safest approach, the approach that has the least complication. Is it, is it possible that there is a very experienced surgeon who has specific expertise in this area and was able to get good results? Absolutely. In a sense, yes, we can, it's perfectly justified to, if the patient, ends up on their door, 100%, they can go ahead and have that. But for the average surgeon who does not have specific expertise in this area, I think it's safer just to allow the fracture to heal and for you to go and fix it later. At least that's my...
I agree with Jayant sir, absolutely. The problem is parents of this kid must have gone to bone setters 2 or 3 times. and then have come with a completely displaced supracondylar at 14 days, and then they say ab sab kuch normal ho jayega na after the surgery. And then if anything happens, if there's stiffness, they blame it on your surgery, that you did a surgery and then it has led to whatever 15 degrees of flexion deformity, which to you must be a very good result because you have gained back functional range. But for them, for that whatever 15-20 degrees of residual deformity, they are going to blame you. So I think we should be quite conservative in especially in cases where there has been a bone setter involved, where there's a lot of massage. We should be laid back and probably give a plaster and allow it to malunite.
Okay, Mandar, a question to you. If bone setter is not treated, I have treated, as an orthopedic surgeon, I have accepted some reduction, but you feel that as a pediatric orthopedic surgeon, it's not acceptable. The patient has come to you for second opinion at 15 days time. Yeah, so how you are going to tackle this?
Highest limit is probably 2 weeks. Though that 2 weeks is a very vague term. And in fact, in very early days, I had asked Taral sir about it. Sir, when is your limit? He said that whatever is enough for mobility. It's like your mom adding salt to the food, that whatever is enough. So whatever is enough for mobility. If the fracture is mobile on table, then you attempt a close reduction and fix it. If it's or with some minor augmented reduction. But if it's not mobile, don't go ahead and dig in the callus and then lead to a lot of stiffness.
Okay, but how to assess mobility? How we can assess unless we take the patient under anesthesia? Is it possible to?
Probably you will have to counsel the parents that I'll if at all they are very insistent on you treating the child. You have to counsel the parents and they say that you are going to take the child under GA and look at the mobility. In case it is there is some mobility and I am able to get at least an assisted close reduction, I am going to fix it. But otherwise, I may not open it actually and do something at that time.
Okay.
I have one question. It was a rare event for me. So how many of you have seen post-operative or maybe you have operated, not operated in the patient developing trochlea avian in a supracondylar humerus fracture? Because that is the cause of a cubitus varus. And sometimes the patient blames that because you operated or because you did not operate, it became a trochlea avian. So is it because of the trauma or is it because of harsh handling of during the surgery?
So it's usually because of the, it usually happens with a low supracondylar fracture, because that artery that supplies the trochlea, it actually goes low into the trochlea from the lateral to the medial side. So if you have a low supracondylar fracture, you can get that. The higher supracondylar fractures have a lower risk of trochlear avian. Mandar wanted to say.
Yeah, so I absolutely agree. So everyone has had, I mean, many of us have had trochlear avians, which we hope is because of the low-lying fracture site. Most of it is, many a times we have cross-pinned at that time. Retrospectively, if you look at it, it's a cross-pinning. So we don't know whether it's the cross-pin which has gone a bit posteriorly, which has led to an trochlear avian. But typically, it is because of the low-lying nature of the fracture site which causes that avascularity.
Because in spite of doing an anatomical reduction, you will still end up with cubitus varus in such a case. Yeah. So that is one of the worst things to happen.
Oh,
that you tell the patient that to avoid deformity, we are doing the surgery, and the deformity eventually happens in spite of doing the first surgery.
Yeah, and it's a malignant cubitus varus. If you have trochlear avian, you also have a medial growth arrest. So even if you do a supracondylar osteotomy, French osteotomy, 3 years later it will come back. So you have to keep, it's trochlear avian is a thankfully it's a very rare problem. I've seen only 2 cases of trochlear avian in supracondylar fracture.
Does it happen more in younger patients with higher energy trauma? How is it? Is it anything in relation to that? Is there a literature supporting this?
That's true. I have not done a detailed literature search or anything, but it's interesting you mentioned that both of those patients are quite young. Actually, at the time of the injury, they were probably less than 5 years of age.
Also almost 3 years old only.
Yeah. They are young patients, younger patients, but I'm not sure what the literature says about it.
Okay. Yes, Rajendra had a question. Yes, Rajendra.
Yeah. In the patients with pink pulseless hand, where we are initially not able to palpate artery, everything goes fine. what is your experience when the pulse comes back? Or do they have some long-term sequelae of a lesser perfused hand?
So I follow a very regimented protocol with regard to pink pulseless hand, which is mostly evidence-based. So I keep them in hospital for 72 hours. And I very closely monitor their perfusion, and I look at the 3 A's rather than the 5 P's, etc. And we have a plastic surgeon who is, available to come and explore. So, we have I wouldn't say we have a low threshold for exploration. I don't like to get the plastic surgeon anywhere near my supracondylar fractures, but we are a lot more watchful of them. So thankfully, I have not had a compartment syndrome. Following a type 3 fracture, I have not had even one compartment syndrome. The only patient who had a compartment syndrome came in with a compartment syndrome. They came about, I think, 48 hours after, in the periphery, they came in with the child already had compartment syndrome. So that is the only experience I have of dealing with compartment syndrome. And I've, treated many Wilkins ischemic contracture, children who have had compartment syndrome and have dealt with the sequelae. So it does, it does happen, and I think we need to be very vigilant. So what I do is everyone has a closed reduction. Even the white hands, they get a closed reduction, and most often the hand pinks up after the reduction. I wait for a little spasm in the brachial artery. So we put a little, warm saline towels around the antecubital fossa to try and allow the spasm in the brachialis, and within 5 to 10 minutes the hand will pink up and it all starts to come back. But in the rare occasion, maybe half a dozen times when I've had to explore these, they have been just white, and in every single occasion there has been some lesion of the artery that required treatment. There was a complete transection, or there was obvious incarceration of the artery, or there was a big laceration of the artery, there was a big intimal injury. So all of those ones that have remained persistently white, I was glad I called the plastic surgeon to come and deal with it.
Yes.
So,
yeah, in a case, there is no vascular injury or neural injury, but there is huge swelling at the fracture site. Do you advocate draining the hematoma to reduce the pressure?
Only if the reduction is difficult and you are using Viraj's suction tip technique. So, but that is only a sort of incidental evacuation of the hematoma. I don't think anyone would deliberately make a nick in a closed supracondylar fracture just to evacuate the hematoma. I have never done that. I have never done that.
Yes. Any questions? Anybody?
Yeah.
Viraj,
So
Rajendra.
Yeah. So when you put this suction tube anteriorly, or your artery, as you said, does it not slip on either side? So how do you make it stay at the point where you want to give pressure? Is it?
So no, I think it's I've never had difficulty because it's a relatively flat piece of bone. So
so it's lower down only.
So it's lower down, and that's why you need to make your incision directly in the antecubital fossa. You have to go make an elbow flexion crease incision. I always find that people go a little bit anterior, a little bit proximal.
Proximal, okay.
But actually, the proximal fragment of the supracondylar
is at the anterior crease.
Is actually in the flexion crease. So just make a small transverse incision in the flexion crease, just lateral to the biceps, and the fracture has done most of the dissection for you all the way up to the subcutaneous tissue. If you literally go through the subcutaneous tissue, you'll see the blood is coming out, and then you can just put your instrument in, and it's very easy. Just have to just flip the brachialis out, push it down, and just pass the pin. So
is it your finger which makes the reduction, or is the instrument which pushes it? You must be palpating and reducing it.
No. The instrument does it. The instrument does it. So I use a straight artery forceps, but I think Viraj, the blunt suction tip gives you a slightly wider surface area. So there is less chance of slippage. So I think even I have used the suction tip, but I didn't have a case where I had taken pictures.
Where we are talking about pink pulseless hand, that is a topic which is very close to me. So this is my first patient in my private practice. First patient when I started my private practice. She was 2 years old then, and now she's I think 16 years old, and she has come back to me. This was a pink pulseless hand. The pulse is still not there after 14 years, or it is very feeble.
It's still not palpable. So
yes, whenever I think about that night, I still get shivers because there was no WhatsApp where I could take opinion of people. I was not in contact with Dr. Taral Nagda, Tushar Agarwal, or Atul Bhaskar Alaric, those who were practicing at that time. This was almost 16 years back. Baby was 2 years old. And because there was no pulse, I thought we should operate at night and then the pulse will come back. After the surgery, pulse never came back. The reduction had to be done open because there was no C-arm. I tried close, nothing happened. I had to take 5 to 6 portable x-rays. And I did not bend the wire thinking that it will slip. And the wire, next day when I came back, the wire had migrated inside. And that wire still remains inside. And that patient was so thankful because she became totally all right that she came to me that usko kuch elbow pain ho raha hai, wire ki wajah se to nahi hai, jara check karo. So I just took an x-ray and saw.
And the muscle bulk and everything is fine for her?
Yeah, everything else is fine, but the pulse is feeble. It is there, but it is very feeble. The SpO2 also, when we were attaching, it was there, but it was not like 100%. At that time, there was SpO2 was also not available in the hospital.
COVID was there at the time. Some COVID percentage of oxygen saturation was less.
And so, but everything is normal. She is now 14 years later. She has come back to me. So I thought I was going to find this X-ray now and show you all.
You propose to remove this pin?
No. No. How I can remove it? It's totally inside. It's totally inside. I don't want to touch her again at all.
Yeah, you should not be unhappy because in one case, the vascular surgeon has repaired the artery, but still it was a delayed presentation, but still the pulse is not there. No, the hand we could survive. So it is all the collaterals which have acted, but still the pulse is not there, So you should not be unhappy because you have not done the repair, at the time.
No, this is a known issue that there is a very high rate of restenosis. There's a very high rate of restenosis within 72 hours. But I think restoring the arterial circulation just pushes the perfusion in favor of not having compartment syndrome.
Correct.
But then eventually the whole thing thromboses again. But by then you've crossed that critical period of 72 hours and body somehow with collateral and thing, it just adjusts. So it's like giving a sort of emergency oxygen loan to the forearm for that 72 hours after the supracondylar fracture.
Yeah.
So even after that, if the brachial artery goes out, doesn't matter. Somehow the body is able to manage. But the important point is, do not sit on a poorly perfused hand. Never sit on a poorly perfused hand. Do not think that perfusion will improve. If the patient has pain, is requiring analgesics, and if you're trying to move the finger, child won't let you come anywhere near. And if there is a nerve injury is a very, very sensitive sign that there is there is deepening ischemia. And a vascular injury, so they are both like villains. If you see them separately, it's not so dangerous. But if you see them together, there is definite danger. When those two villains are plotting together, you can be sure that you have to do something about it. You have to explore. And all the nerve papers talk about ischemia, and all the vascular papers talk about associated nerve injuries. So there is some deep association between the two.
But what is the most common nerve injury that you have seen? Okay, sir. Sorry.
No, it's fine. You can continue. Yeah.
What is the most common nerve injury that you have seen, Dr. Jayant?
Anterior interosseous nerve.
I have not seen a radial nerve injury. Have anyone seen a radial nerve injury in a supracondylar? When does it happen? Does it happen in a specific type of fracture, a specific type of spike or something?
No, they say post-medial displacement. But the large meta-analysis of 5,000 fractures found no correlation between the type of nerve injury and the configuration and the displacement of the fracture. They found absolutely no correlation at all. The only correlations they found was that if you have a flexion type supracondylar, there is a very high risk of ulnar nerve injury. And if you use a medial pin, there is a slightly 1% higher chance of getting ulnar nerve injury. And if you use lateral only pin, there is a slightly higher chance of getting a median nerve injury. And why a lateral only closed pin would cause a higher rate of median injury, no one is able to explain. But that's what the large meta-analysis said.
But that AIN, does it recover after the fixation?
Yes. Yeah. So I have not had one case of nerve injury not recovering when it has not been due to compartment syndrome.
Okay.
The nerve injuries that happen due to compartment syndrome and Volkmann's ischemic contracture, they are a completely different ballgame. But when you have just neuropraxic injury without compartment, they predictably recover within a few weeks, if not 3 months. They all predictably recover. That's, I think all the other faculty are also nodding. So I think that's been the general experience. So you don't have to really lose sleep over it.
Yes. Any last question? Viraj Chandak, I'll come from Viraj.
Yeah, that's fine. Yeah.
Okay. Ashish?
No question.
No. Yes. Mandar?
No. I think
no.
Chandak
Yes.
sir is waiting.
Yeah. Rajendra?
Yeah. So what is your one good sentence which doesn't frighten the parent and you still keep ourselves safe about a supracondylar? Either you do a pinning or a close manipulation, warning them about a cubitus varus or some restriction of movement. Any good sentence you have coined or something?
No.
So that they are not frightened.
No, I just go out like a champion, and you know how it is. You just say, it'll all be okay. I've done 1,000. What? So when you're actually in that, whatever you may say in the webinar, when you're there, in your OT dress and you are the champion, you can't go and make some little excuse like that. It's very unorthopedic to do things like that.
Rajendra, don't tell anything before the surgery. Once you do the surgery, when they come for follow-up, give small dose. This is a injury near the growth plate. Even though it has 100% correct now, there might be some growth disturbance because that I cannot predict. Then even for a transcervical fracture, I tell, I've done my job, very good, but chance of AVN is there. We have to keep repeatedly taking X-ray till about 6 months time. So small doses you have to keep on giving. So don't tell.
But it also depends on how things are going. It also depends on if things are going well, then you don't really want to give them some big Ramayana about this and that.
Yes.
But if things are slowly going in some unpredictable direction, then I think the smart surgeon would start to hedge the bets and start to expose them to a little bit of the bad news and all that. So it's all the art of
counsel.
So
Viraj, any sentence you utter? Let us follow up up to
Viraj will have. He'll have a punchline. Viraj, you know.
Trust God, and then everything will be fine.
Okay. So that was Jayant. That was a wonderful exposure to supracondylar fractures. What to be done, what not to be done. Okay, yeah. Everything you have covered so beautifully, and also treatment of type 1 is just give slap. Type 3 and type 4 is you have to operate and reduction and pinning, and type 2 is where we have to take the call and we have to, whatever the way we are treating, either conservatively or operatively, we have to be very careful to see that the displacement doesn't progress in the plaster which we are treating conservatively, and pinning might be a better option if the patients are not coming for regular follow-up. And all the things you have covered beautifully. Thank you for that. I would like to thank all the panelists, Dr. Mandar Agashe, Dr. Ashish Ranade, Dr. Viraj Singade, and Dr. Rajendra Chandak for this wonderful interaction. Almost for 45 minutes we are interacted after the talk is over. So it's a great interaction we had, and almost all the points have been beautifully covered. Thank you, Neeraj, for this wonderful platform. And next Thursday, we have got one talk series, Dr. Prasad Gaurineni from Chicago. He'll be talking on hip evaluation and treatment in painful hip without any arthritis. So again, for all the pediatric orthopedic surgeons who are watching. It will be a very good topic. All of you will be knowing Dr. Prasad Gaurineni, and he'll be talking on this interesting topic next week. Thank you very much for watching this.
Thank you.
Yeah.
Thank you so much.